all of you here, I think, well, most of you, are young enough to have a rather limited perspective on history. I'm rather older, so I have a rather long perspective on history. And sometimes it's important to see how things develop and how you get to where you are at now. I'm a university physician, but this is not my first specialty because the specialty of emergency medicine only started in Israel about 18 years ago, 19 years ago. So I first trained in diving, hyperbaric medicine in the Navy, and then trained in anesthesia, then in intensive care at Ohio State, and then in emergency medicine. So I sort of moved around a bit, and I've been in emergency medicine for the last 25 years, running a rather large emergency department that I will describe to you briefly as well. So Israel is a small country, about half the size of Switzerland, population about 8.9 million. In spite of what you may see on CNN and so on, we have a fairly high quality of life. We have the 8th, I think, longest life expectancy in the world. Our neonatal mortality is way lower than the US's, and it's pretty good. Our health expenditure is 8.6% of GNP, and because we do have universal medical coverage, single payer systems based on 4 HMOs, we all pay 8% income tax that goes directly to health care and distributed to 1 of 4 HMOs based on capitation. So you can join any of them and you can switch between them. They cannot deny you care, they cannot deny you membership. And they must provide you with everything that's in a government-mandated basket of health services that's out there. It's not everything, but it's, I guess, 95% of what most persons need, up to and including highly sophisticated care and so on. Medical history starts a long time ago everywhere. So this is one example in Israel, then Palestine, 1915, World War I. This is the Turkish Field Hospital. This is the ER at the Turkish Field Hospital. Palestine was conquered by the Turks in 1917 when it was taken over by the Brits. And this is the first ER in Tel Aviv, 1909. It looks very similar to my ER at the present time, except for maybe most of the people do wear shoes. But other than that, it looks similar. And this is the first general hospital in Tel Aviv in 1939. It was actually built in 1925. I don't have an earlier picture. So the medical system developed gradually, and it took a while. We talked about infant mortality. Maternal mortality is also fairly low. We number 145 among 150, so 5th lowest. Chances of reaching 65 are fairly good. We do smoke too much. Our health expenditure is not that high, and it's certainly too low. We need to increase it. Corruption is not that bad. We feel it's much worse than it probably is. Everybody does, I think. And we have a fairly educated workforce. Other issues such as patents issued, if you look here, Israel is number 12 in the world in absolute number of technology patents that we submit and are granted. Although we are a small country, our expenditure on research development is number 17 in the world, and we could do a bit better with higher education with number 22. It's not that bad. Health expenditure increases, but it's below the OECD level, and the percentage of households with additional health coverage is increasing because of that. But additional health coverage, meaning that you provide yourself with private medical insurance as well, costs about $50 to $70 per family per month. So it's not that big a financial burden. That's why most people do have it. We do not have enough ED beds, and the ratio of ED beds is slightly decreasing. But that's good because also the ratio of ED visits is slightly decreasing, mostly because we have universal GP coverage for everyone, and there is an increasing number of standalone urgent care centers which can provide care for minor injuries and minor medical conditions. So the actual number of ED visits is not increasing as much, which is a good thing, because you are in a very large country, very geographically distributed, so you need a large number of small hospitals as well, certainly in rural areas. So you have 4,000 or 4,500 hospitals. We have only 28 general hospitals, but they tend to be pretty big. We have 6 level 1 trauma centers. We do have a mandatory surge capacity because of the geopolitical realities of the country. Every hospital is mandated to be able to receive 20% of bed capacity within 2 hours. So for my hospital, we have 1,450 beds. We are mandated to be able to receive 300 casualties within 2 hours in the hospital 24/7. And we sort of build ourselves to that end, and I'll show you that. There's about 3 million ED visits per year in the country. And emergency medicine has been a specialty since 1999. When did emergency medicine start? In 1976?
Yeah.
So, Cincinnati was it?
Mid-70s.
Okay.
Yeah, 75, 76.
So you have an advantage of us that way. And I'll talk about that in a bit. By the way, when we tried to start emergency medicine in I was the president of the association, or the Emergency Medicine Association, that in 1996 I tried to convince the government that we needed a specialty. The first question they asked, and not everyone in government is stupid, most of them are, but not all. The first question they asked, rightly so, was, what do you think? What was the first question they would ask?
How much is it going to fund it?
No? Sorry?
Who's gonna run it?
That's two. The first question that you ask when somebody wants something new is basically, why? Why? Why do we need that, and what would be the benefit to the country and to the population of the country by setting up a new specialty? We, at that time, already had about 50 specialties and subspecialties in medicine, and we were going to be number 51. We ended up being number 54 in the end. So we have so many specialties, subspecialties. Show me the proof in the literature that setting up emergency medicine as a specialty improves patient care, decreases costs, improves efficiency, does all the good things that you claim it's going to do. You know what? There was not a single study that showed that, ever, at that time. There are very few studies at this point in time that have ever shown that emergency medicine, setting up emergency medicine as a specialty, does all those good things that we all wanted to do. That is, improve care, quality of care, decrease cost, and increase efficiency. It's very hard to show that scientifically. It makes sense to all of us, but it's very hard to do that. So, given that we could not find data to show, what we did at the time was we did what politicians would do. We tried to convince people on a personal level. So basically I found out who the chair of ASEC was. It was then Professor Agababian, Dick Agababian at UMass. And we became friends very quickly, and I asked him to come and give a lecture at our annual meeting. It was the second annual meeting of the association ever. And also to meet with government officials and the Minister of Health. And he did, and he met with them. And he was a very forceful, I don't know if any of you knew him, he was a very forceful, very convincing person. And he invited them over to UMass to visit and see how emergency medicine was being run. That was 1998, I think, at UMass, and they did. And they came back and said, you know what, I don't know if it will do something good, but it seems to me, it seems to make sense. And we basically convinced the politicians, and from there on, we succeeded within 2 years to have a specialty. So if you need anything done, all you need to do is have somebody with outside authority, basically, come in and convince the people empowered to change their minds. At least it works for us. These are the numbers, excuse me for the Hebrew, but look at this. These are numbers in thousands of patients seen in every single one of our EDs. So this is one that's in 187,000 patients. This is excluding OBGYN. So it's adult and pediatric patients excluding OBGYN and obstetrics. This is another hospital seeing 160. And this is my hospital, which saw in 2014 208,000 patients. It's now up to 220,000 patients. So we have a small number of EDs which are very, very busy. We see on a regular basis 420 to 430 patients a day, adult patients a day, another 100 kids or so. Busy Sundays, which is your Monday, we would see 500 to 520 adult patients and about 150 kids. So we tend to be pretty busy. We started off in emergency medicine as a super specialty. They didn't want us to have a specialty right away, so they said let's have fully trained, board certified physicians, mostly internists, who already know medicine as it were, retrain in emergency medicine and see what will happen. And that's what happened for the next 9 years or so. We started with that, and in 2010, we were awarded the primary specialty status as well. We currently have not 40, this is not updated, I'm sorry. We currently have about 140 residents training in the country. I have 15, and it's growing, but we're not there yet. One of the issues is that you have funded residency positions. So if I were the chair of emergency medicine here, I'd like to have as many residents as I possibly could, because I would have made money out of the positions that were funded as well. We have a certain number of FTEs, and these FTEs I can fill within the residents or attendings. So it's always sort of a balancing act. If you have more attendings, then you are more effective, of course. If you have more residents, then you invest in the next generation, which is also very important. But attending give 100% almost, 80% of the time to work, supposedly. Residents only give me about 35% of their time, because they have so many rotations and they have so few hours that they work during the daytime because they have night shifts and so on. So we end up getting not very much work out of them during daytime. So it's a balancing act that we try to figure out how to do. I was at Isreal in Boston last year, and I looked at the numbers. And there are much smaller hospitals than we are, but they are a large academic center. And I compared them, physicians, nurses, everybody basically, staffing and space and so on per patient. And the ratio is about 1 to 3. So I don't know your ratio pretty much, but their ratio is about 3 times as many physicians per capita, per patient that we have, 3 times as many nurses, 3 times as much space, 3 times as much cost per ED visit, by the way, and so on. We suffer from a lack of staffing and a lack of FTEs that we can fill out as well. And we have to make do with what we have. Ends up, as I show you, not too badly. We have the Association for Emergency Medicine, which is the professional body of emergency medicine. We do now have emergency medicine trained specialists in almost all EDs as chairs. Some of them, like myself, are still old guard who trained in previous specialties. But I think I'm one of the last 3. All others have been trained either here, or in the US, or in Australia, emergency medicine. We do have the first University Department of Emergency Medicine, which I happen to chair, and we have now 8 associate professors. But our threshold for professorships is very, very high. You need about 150 peer-reviewed papers to get a professorship at my university. I think that's significantly higher than most American universities. So it's hard to get there. There is no law that governs emergency medicine as such. We set our own standards, which is good and bad, of course, but at least we have control over that. Malpractice is not a major issue in as far as we don't pay a lot for coverage, but it's becoming a significant issue for the hospitals. And both the worst challenges are that we need to attract good people, like yourselves, who want to work in a very challenging, not very well paid, very stressful environment. And when we started emergency medicine as a primary specialty, that was out of med school almost 10 years ago, we were a bit unsure about what the quality of the people who will elect to choose such a specialty will be. And I frankly must say I was very pleasantly surprised to see that we get the best people. We really do. And I think it makes sense up to a point, because we get the people who really want to work hard and to have immediate rewards. I don't know any of you, almost, but I would guess that you are different than oncologists or nephrologists who get their rewards 6 months down the line, which is great. We get our rewards 5 minutes or maybe 5 hours after we started taking care of the patient, which is a different way. But then you move, meanwhile you do so many other things. So we were able to attract very good people like you do, which is great. We still have a while to move. We have to advance academically. I don't know how much research you do here. We are trying to do quite a bit, and we are advancing, but it takes time. It is a challenge. We do not have enough protected time. We do not have enough support system. A few words about my hospital. This is the Tel Aviv Medical Center. It's a 1,450-bed university hospital, level 1 trauma center. We see 145 adult patients per year. We have 64 beds, 5 trauma beds, 5 fast-track exam rooms. We have about a 27 to 30% admission rate. Our length of stay for discharged patients is 3.2 hours and about 5 to 6 hours for admitted patients. We have 15 emergency medicine residents, like I said. Daytime, we have full EM coverage. After hours, we have only partial coverage with EM attendings and residents supervising residents in internal medicine, surgery, and orthopedics to do the bulk of the work. And we are busy. This is what the ER looks almost every day. The new one that we're building will hopefully look better. We have challenges that are beyond emergency medicine, such as being on a constant threat of war and rocket attacks. So the ER is basically a bomb shelter as well. But it's also, built to please patients on a regular basis in trauma room. And we sometimes get pretty busy. Our patients tend to come around noon and around early afternoon. I think it's the same for you. Yeah. Pretty much this sort of high model peak. This peak for us is mostly because of GPs who send their patients to us after morning rounds. One major problem that we have is a significantly increasing number of admitted patients that we board because we do not have enough inpatient beds. I think that's something that you know about. For us, the problem is getting worse. These are the number of hours of boarded patients per year. So we've gone up from 1,000 in 2014 to 3,000 in 2018. So it's not that good. Not much we can do about that. And as far as residents, we have our resident Wednesday, like you do. And then there's Tuesday morning as well. And then we have a simulation center. We just finished building a large simulation center in the hospital that we will run. So we'll have first digs at all the sophisticated equipment that's in that simulation center, which will improve things. So we do a lot of simulation. And we even managed to publish, these are some of the papers that came out of our department in the last few years. So we managed to publish mostly clinical studies, some lab as well. Of course, the staff is what really matters. We are building a brand new emergency department that started building last week. It's going to be 100 beds, 3 floors, a 30-bed observation unit, 10 fast-track exam rooms, an MRI, and 2 CT scanners. It'll look, hopefully, something like this. So things will improve, at least as far as physical layout. And there's, of course, the challenges of terrorism and war. We've had many, many terror attacks through the last years. So the country is sort of geared up for that. This is my granddaughter's kindergarten, where they have a ball shelter as well. And it was used, unfortunately, a few years ago during multiple rocket attacks on our town. And the EMS are built to cope with that. And the ED is built to cope with that. So when I planned this in 1998, it was also planned to cope with a large influx of casualties because of multiple events. So it has a one-way flow system. I won't bother with details, but when we build our ED, we also take into account the possibility of hundreds of casualties coming in very, very quickly. That's why we have electronic support means, such as we have a smartphone-based patient control systems that allow us to access and control patient movement in the ED and actually access every patient's EMR while it's going on. And we have an underground car park that can quickly be turned into a 750-bed underground emergency hospital, which is bomb protected and so on. And you know what? In spite of all of that, and it sounds to you like it's hard, it is, it's crowded, and it's extremely busy, and it is, and we have a hard time gearing up towards improving our residency and improving our specialty. We still do quite okay. This is a UN report. This is the last one I had in 2015, and Israel turned out to be the 11th healthiest country in the world, whereas the people are. Maybe they were on something when they filled the questionnaire. Cannabis is not legal in Israel, but police look the other way if you only use it. So selling it is illegal, using it is sort of not very frowned upon. Everybody pretty much does, including in the hospital. I mean, literally, patients, we have a lot of medical cannabis use, and patients come in with a cannabis supply, and they actually smoke for whatever reason they do. Supposedly pain control in the hospital or in designated spaces. So this is a very briefly emergency medicine in Israel. If you have any questions, thank you very much.
Thank you very much. This is great having you here. My question is, since you have universal health care and everybody has a general practitioner, primary care doc, why are the emergency departments utilized so much? The whole country has 9 million people, less than 9 million people. So I'm just curious, is it because it takes a long time to get an GP?
We have the same ratio of ER visits as you do. Basically, it's about 0.34 or something. The overutilization is because we are open 24/7. Because we can offer, of course, specialty consults 24/7, and we do. If you come in with long-term joint pain, and you ask to see a rheumatologist at your HMO, and they told you that it's going to be 6 weeks, if you come into the ED, you'll be seen by a rheumatologist within 3 hours, and bitch about it. 3 hours? You know, but you will be seen by one. Who will start, you know, the diagnostic process sometimes already tap you, look at your fluid, and give you a diagnosis. You know, so it's easy, it's convenient.
correct me if I'm wrong, but in like those situations where somebody comes into the ED for, you know, something like that, don't they have to pay more? Don't they get a fine?
No, if you come into the ED, you pay a
let's
global
just
fee of about $210, which 90% of people do not pay because the HMO will cover it unless the guy is really stupid and wrote something silly like, I wanted to come in spite of having great care from the HMO or something. But if you have anything like semi-urgent, there are so many conditions that are automatically covered. Any headache, any chest pain, any acute abdominal pain, anybody who's pregnant. There's so many things that you when you put down on your reason for coming will be automatically covered, that only about 10% of people pay anything at all. And it's not fee for service. So you can get an MRI and 3 consults and everything done, still be those $200. And I'll give you my take on this. I believe in good quality medicine, which is efficient and provides care. If we do 70 to 100 CT scans a day, if the CT scanner is taken and have a list of 20 people waiting for the CT scan, and somebody comes in with 2 months headache, I tell them, go ahead and get the CT scan in the community. But if I have like 2 people waiting for the CT scan, it's not really busy. And he's so scared, and frankly I'm scared too, because once in a while they have something. I'll do the scan. I don't care. I want to give him good quality medicine. And for me, it doesn't matter who does it. As far as the country is concerned, it's the same pocket. So it's not like I will be defrauding somebody or something. Good.
Here we have Intala that kind of dictates that we have to treat, stabilize every patient while symptom worsening, similar to some
We do, yes. We absolutely have. That's not specific to emergency medicine. There are laws that basically state that anyone seeking medical help will be seen by the facility they came to, even if it's not an emergency department. So yes, we have something similar.
And here that also tends to apply to people visiting from other countries. Is that the same in Israel?
Absolutely. And if you come from another country and don't have the clerk at the door will ask for your insurance. We'll even sometimes try to get your Visa card, swipe and so on. But if you are urgent or if you need care and you don't have it, you'll always get care regardless. And then somebody else will try to get somebody out of it. Or not. Thank you very much.
All right, so we can take a 10-minute break. We'll start promptly at 11.